Yes, sir. Three, two, one.
So a very good morning again. Welcome to the teaching class of Department of Urology, Savai Mansingh Medical College, Jaipur. Today we have a presentation on hypospadias, which is a very common congenital abnormality. And this would be presented by our resident, Dr. Naveen, and would be moderated by our faculty, Dr. Somin. So I would request Dr. Naveen to kindly go ahead with his presentation. In the meantime, I would welcome our experts today, Dr. Gyanendra Sharma, who is a consultant urologist at Sholapur, and Dr. Anil Takwani, who is from Junagadh, Ahmedabad. He's again a consultant urologist. Both have a special interest in pediatric urology, and both are quite senior people, and they are part of the pediatric urology, which is the subspecialty in the Urological Society of India. So I welcome both the experts, along with Dr. Amilal Bhatt, who has been regular joiner with our classes. And thanks all the experts for joining us. And now I will ask the resident to present. Please go ahead.
A very good morning, respected teachers, seniors, and colleagues. I am here to present my seminar on hypospadias. So, hypospadias is simply meaning the ventral opening of the penis with some amount of penile curvature. Hypospadias is the most common congenital anomaly with the incidence is 150 to 1 in 150 to 200 live birth. Mainly, the hypospadia is a single isolated penile defect, but it may be associated with the part of syndrome. Nearly 200 syndrome associated with the hypospadia. Some are WAGR syndrome, Dennis-Dress syndrome, Smith-Lemli-Optic syndrome, hand-foot genital syndrome. The hypospadia is 10% familial. With the increased incidence with the first degree relative is about 13% time higher risk to be a hypospadia. With the brother, 19 to 70% chance of being affected with hypospadias. With the twin, 99 to 27% to be a hypospadia. Hypospadia is significantly associated with the deletion of the chromosome band 1, 4, 7, and 11, and the duplication of band 2q. The risk factor associated with the hypospadias are premature birth, small for gestational age, less than 10% percentile of weight, intrauterine growth retardation, extreme maternal age, less than 20 years or more than 40 years, maternal smoking, diabetes, pregnancy-induced hypertension, and preeclampsia. Embryology with the urethral development is the urethral groove which is appear on the ventral surface of urogenital fold, which is lined by the endoderm. By the 16-week fusion of urethral fold is usually completed, and by the 18-week the penile development is also over. The urethral development is a complex procedure with these two separate process. Complete urethral development done by the fusion of the urethral groove from proximal to distal, from proximal penis to glans penis, and canalization of the glans from distal to proximal. By these two separate process, development of urethra occur. Some theories is associated with the hypospadias. First is ectodermal ingrowth theory. By this theory, granular urethra meatus normally invaginate and fuse with the distal end of urethral plate. And the disorder of this fusion will lead to hypospadias. In Kazarov theory, the urethral plate continues to grow to distal tip of meatus and later gets differentiated into squamous cell epithelium, and the failure of this differentiation lead to hypospadias formation. Classification of hypospadias in 1938, Smith classified the hypospadias in first degree, second degree, and third degree. Later on, Schaeffer, Avalon, Brown, and Duquette classified the hypospadias on the basis of meatus opening in glandular, penile, mid-shaft, perennial, mid-scrotal, and perennial. A new classification which is given in 2003 classified the hypospadias in granular and distal hypospadias and proximal hypospadias. Distal hypospadias is subcoronal or mid-shaft hypospadias, and beyond the mid-shaft hypospadias is classified under proximal hypospadias. Glans meatus and penile shaft score. The score used to calculate the severity of the hypospadias using G score. G score represent glans size, urethral plate, and development of the groove. While M score related to meatus score, opening of the meatus, the granular opening, coronal, mid distal shaft, or proximal or penoscrotal. While the S score related to the body of the penile, there is no body, mild body less than 30 degree, moderate body 30 to 60 degree, and the severe body. The GMS score, higher the GMS score correspond to the severity of the hypospadias and poor outcome of the surgery. The diagnosis of hypospadia is mainly based on physical examination. On examination, and ectopic ventrilocated urethral meatus with the penile curvature and incomplete preputial development ventrally and dorsal hooded prepuce. Radiographic evaluation, generally radiographic evaluation is not indicated in isolated hypospadias regardless of the severity, but radiographic evaluation indicated in severe complex hypospadias with cryptorchidism. In these cases, the evaluation including ultrasonography of the upper tract to look for renal agenesis, karyotyping for DSD, for intersex evaluation, micturating cystourethrogram for presence and extent of prostatic utricle, and sometimes endoscopy may required. Now, pre-op evaluation of the hypospadias include foreskin, which is poorly developed, well developed or poorly developed or absent, glans and group configuration, urethral plate. The urethral plate, well developed, hypoplastic, broad or narrow, penile size, normal or reduced, curvature of the penis, present or absent, position of the meatus, and the scrotum, normally hypoplastic, bifid or transposed. Now, come to the timing of the surgery. The good tolerance of surgery and anesthesia by the age of 6 months and the genital awareness by the age of 18 months. So the most suitable age for operation of hypospadias is 16 to 18 months. A role of pre-op hormonal treatment is in hypospadia surgery is controversial. The hormonal treatment is given for penile length and glans width because glans width less than 14 mm of size associated with the increased risk of complication, which is reported by Bush and et al. In 2015. The agent of pre-op hormonal therapy available are local application of testosterone. 5% testosterone cream is available for local application, and intramuscular injection 2 mg per kg before 4 week and 2 week of surgery. A systemic review and meta-analysis by Ghazali et al. Concluded in their study there is a decreased complication risk for glandular dehiscence with pre-op treatment with the androgen, but there is reoperation rate, UC fistula, meatus stenosis, penile scarring. There is no significant difference in testosterone treated group and control group. What is our aim of surgical management? Our aim is correct the penile curvature to ensure a long and straight erection, so patient can able to masturbate in standing position, and there is no curvature during sexual intercourse. and advancement of urethra to ensure normal passage of urine and semen through the glands, and creation a cosmetically pleasing penis, so near normal appearance of the phallus. So now come to one causes of the hypospadias. The caudy is because of the entrapment of the corporal body in the covering of the penis. Caudy can be due to short ventral skin, short dartos fascia, short asphyxia, short corpus spongiosum, dorso-ventral disproportion of corpus cavernosa, and congenital short urethra. Either a single factor or a combination of these factors can cause caudy. So now come to assessment of the caudy. Assessment of caudy is done by three methods: Gitti's method, vasoactive drug, or elastosonography. Gitti's and McLaughlin is a commonly done test. In this test, after tourniquet in the base of penis, normal saline injected in the corpora, and assessment of caudy is done. But Gitti's and McLaughlin test, the most common disadvantage is supra physiological and sub physiological filling of the corpora. So underestimation or overestimation of caudy is the main disadvantage of the Gitti's method. With the vasoactive drug, the main advantage of vasoactive drug advantage is a physiological assessment, then erection by the injection. The main disadvantage with the vasoactive drug is a long-lasting erection, and reversal may require with the vasoactive drug. In the elastosonography, the modality, this is a new modality, and this allows the real-time assessment of the stiffness of the tissue in a focus area. Now come to one step-to-step correction of caudy with preservation of urethral plate. Some amount of caudy get corrected after degloving of the penis. After degloving of penis, the second step, if caudy is persist, is urethral plate and corpus spongiosum mobilization up to the corona. After mobilization of spongiosum up to the corona, third step is urethral plate and spongiosum mobilization into the glans. After that, proximal urethral mobilization, dissection of the T3 tissue, midline dissection of the corporal body and lateral mobilization of the buccal fascia. Spongioplasty and granuloplasty can also reduce some amount of caudy. Single stitch dorsal plication if caudy more less than 30 degree, and superficial corporotomy and corporoplasty if caudy is more than 30 degree. Lastly, plant disassembly and with or without corporoplasty. By the orthoplasty, we want a straight penis. So step of orthoplasty is the skin degloving, dartos dissection, release of corpus spongiosum corpora cavernosa. I already discussed, and injection of normal saline into the corpora by the Gitti's and McLaughlin test. If a caudy less than 30, you can go for a dorsal plication. If a caudy more than 30, go for a ventral corporotomy with or without grafting. By the spongioplasty and granuloplasty, some amount of caudy get corrected. By the mobilization of the spongiosum, make the spongiosum from Y to I, increase the length of spongiosa, and the caudy get corrected. By the glansoplasty, after well mobilized granular ring, reconstruct the normal looking glans and correct the granular caudy. And next bit describe the technique for caudy correction by the elliptical excision biopsy at the dorsal tunica at the point of maximum curvature. And Henke-Miculis describe the make a vertical incision in the tunica albuginea and horizontal closure of the defect, but it lead to shorten of the dorsum of the penis. Vaskin midline plication is similar to Henke-Miculis plication. In Vaskin midline plication is a midline vertical incision in given, and which is closed transversely in avascular planes. Ventral corporotomy is needed when body more than 30 degree. Ventral corporotomy done from 3 to 9 o'clock at the greatest venting area and opening of the tunica albuginea and patched with graft or flap. The most commonly graft material used tunica vaginalis graft or flap is tunica vaginalis flap, non-hairy dermis from the groin and small intestine mucosa. So, by the steps, body correction and the etiological factor corrected are by the penile degloving, the body because of skin, dartos fascia, wax fascia get corrected. After mobilization of the spongiosum, body because of spongiosum get corrected. Resection of body tissue, midline dissection and lateral dissection, body because of wax fascia get corrected. Spongioplasty and granuloplasty, body because of spongiosum get corrected. Dorsal plication, superficial corporotomy and corporoplasty, body because of dorsoventral corporal disproportion get corrected. Now come to urethroplasty. Urethroplasty is a formation of new urethra with the new urethral coverage. The first layer is a formation of new urethra, which can be done by immediately adjacent tissue, which is less risky and least technically challenged. It is a simple tabularization of the urethral plate. We can use a local tissue flap, example, fasciocutaneous flap or dartos fascia. Local or extragenital free flap like BMG, which is most commonly preferred. For a coverage of new urethra, there are some flap are available, dartos flap, tunica vaginalis flap, and corpus spongiosum. While the second covering of new urethra, it significantly decreases the UC fistula. New urethra coverage technique, a ventral transfer of the superficial skin either by the buttonhole technique to the ventrum of the glans penis. We can go for a midline longitudinal split of the prepuce and lateral transfer of skin on either side of the penis on ventral coverage and transverse outer preputial island flap can be used. There are many techniques available for distal hypospadias repair. TIP, which is most commonly used, which is popularized by Professor Snodgrass, make by technique metal advancement and glanoplasty incorporated. Matthew flip flap flap, Thias duple tabularization, duple online isolate flap. Mid-shaft hypospadias, the technique are available TIP and duple online isolate flap. For a proximal hypospadias, in proximal hypospadias, well-developed, good caliber urethral plate is available. The technique are available TIP, duple only, and split prepuce in situ only flap. For a when urethral plate is unavailable, one stage operation or two stage operation for hypospadias repair. One stage for TPFI, inner transverse preputial island flap, which is known as a Duquette tube flap, Konyangir flap, for a two-stage flap, Burka flap, and Wyeth flap. Now come to TIP urethroplasty. The original TIP urethroplasty is most commonly used for operation for a distal hypospadias repair. In this hypospadias repairs, first step is penile degloving and correction of the body. After correction of the body, urethral plate mobilized. After mobilization of the urethral plate is incised. After incision of urethral plate, a stabilization of the urethral plate done over a IFT or stent. And after stabilization, dartos cover is given. Glanoplasty and skin cover is the last step of TIP urethroplasty. Some modification are also available for TIP urethroplasty, like spongioplasty, glanoplasty, spongioplasty, and lastly frenuloplasty. Matthew flip flap technique. In the Matthew flip flap technique, Matthew technique is used for coronal or subcoronal hypospadias. In this technique, the measurement of distance of glans tip to the present meatus is calculate and the distance calculate as a x, and the same amount of distance is also required proximally to the meatus. So after marking of the flap is created and flap is transposed over a distal flap transversely, and second layer covering done with the dartos, followed by the glans and skin closure. For Matthew flip flap technique, the skin proximal to meatus should be thick and pinchable. So now come to on technique for proximal hypospadias repair. Inner transfer superficial Iceland flap, which is given by Duquette tube. This is used for proximal hypospadias. After penile degloving and correction of the body, mobilization of the inner superficial flap. After mobilization of the inner superficial flap, tubularization of the superficial flap done over 10 or 12 French catheter, depending on the age of the patient. After tubularization, the flap is transposed to the ventral side of the penis, and the flap is anastomosed to the proximal urethral meatus, and creation of the tunnel in the glans. And after creation of the tunnel, this tubularized flap is pulled through the glans channel or a tunnel and anastomosed to the glans with the interpreted suture and closure of skin. A wire flap is used for a two-stage operation in which body more than 30 degree and proximally situated hypospadias meated. In wire flap, dorsal prepuce flap is used and is split down in midline, and the two part of this flap is transferred ventrally, and their dartos vascular pedicle are sutured into the defect from the meatus to glans. And the second is second stage operation is done over a previously transferred prepuce, and the previously transferred prepuce is tubularized, and after that spongioplasty can be done, glansoplasty, and the bias flap technique is used for after following corporotomy with grafting by those who prefer a two-stage urethroplasty rather than a single-stage tubularized preputial flap. Complication of hypospadias. Acute complication of hypospadias are bleeding, hematoma, infection, and chronic complication are meatal stenosis, UC fistula, urethral divertism, VXO changes, recurrent stricture, glans descents, sexual dysfunction, and infertility. This factor associated with the complication of hypospadias are proximal meatus, reoperation, glans with less than 14 mm, and poor barrier of flap over the near urethra. Meatal complication, most common complication is stenosis. The causes of meatal stenosis are technical error, ischemia, and VXO changes. Treatment is simple dilatation, or in a refractory cases, simple dorsal meatotomy to YV granulomyotoplasty or ventral flap using tissue only. UC fistula is the most common complication, and expected incidence is less than 5% for distal fistula. Fistula because of technical error or technical factor, and technical factor to reduce the incidence of fistula, to close the new urethra in two layer and cover the new urethra with barrier flap, usually with dartos. Examination associate the condition like distal obstruction before repair of the fistula. A small fistula may heal conservatively. If fistula beyond 6 months persist, reoperation is required. New urethral stricture, the most common site is proximal anastomotic site. It is usually present within 3 months of surgery and rarely seen with TIP repair. The initial treatment, conservative with dilatation or DVIU. Retrieuproplasty is indicated for intractable cases. Dehiscence is a partial or complete dehiscence cause recurrent hypospadias. Proximal repair are more likely than mid and distal repair. The risk factor is small glands closure under tension is the main risk factor. Dehiscence correlate with the graft source in case of BMG arthroplasty. Dehiscence below corona, reoperation is required. Diverticulum, there is ballooning of neourethra with postboard dribbling suggestive of diverticulum. The most often after tubularized prepucial flap, rarely seen with TIP. For treatment of diverticulum, midline ventral skin incision, neourethra opened in midline and diverticula excised. In only flap, excise the flap, preserve the pedicle to use a second layer barrier flap. The VXO required excision of all involved tissue and their replacement with non-skin tissue like buccal mucosa. Sexual dysfunction and infertility with the hypospadias seen with persistent because of persistent body, inadequate cosmetic outcome, penile torsion, or small penis size. Small penis size is an uncorrectable cause, and the other factor are proximal hypospadias and repair after puberty. Hypospadias, reoperation, the most complication of hypospadias need extensive multi-stage operation with a surgical plan. And surgeons should not be tempted to attempt a small operation, hoping that convert the failure with the minimum effort. Each visit to OT leave a penis progressive scar, so changes the established blood supply and decreased tissue option for reconstruction, all of which result in increasing complication rate with each unplanned operation. So we need a period of assessment for reoperation of the hypospadias. First, assess the original meatus location, ventral curvature, number of prior operation, and date of most recent one. Generally, reoperation is are delayed until 6 months after the last operation. Surgical algorithm for reoperation, hypospadias reoperation should be approached systematically. If there is a Cody less than 30 degree after degloving, release the contacted scar. TIP is the first choice or first consideration. If Cody is more than 30 degree, the new urethra and all ventral scar must be removed and the penile straightened and after the stage performed. Salvage hypospadias for a focal issue, fistula and diverticulum in the absence of penile curvature can be performed using local or remote skin flap. Follow-up of hypospadias for a distal penile hypospadia, distal TIP assessment at 6 weeks and then 6 months later. And for a proximal TIP, annual follow-up is required with the goal of determining functional outcome pre and post puberty. The 80% of complication diagnosed within the 1 year of surgery for a patient with small less than 3 years to rule out the obstruction. We do a calibration, and the calibration is indicated in an infant with questionable obstruction, voiding, and small appearance of the meatus. Thank you.
Thank you, Naveen. So before we invite our experts today, I would like to apologize on behalf of the presenter that we have missed Dr. Asopa. Dr. Asopa, I think, was a big name in Hypospadias, and I would like to dedicate this class of ours to Dr. Asopa. Asopa, we know there are a number of surgeries by the name of Asopa. Asopa's not island flap, but the Asopa's flap for only flap urethroplasty. And then he also innovated the graft procedure in Hypospadias. which we can call a snot graft or Asopus procedure after the tubular is incised urethroplasty. So definitely we cannot forget Dr. Asopa when we talk about hypospadias. And definitely Dr. Amilal Bhatt, our own urologist from our own alumni, he has done a lot, contributed a lot in hypospadias, particularly the concept of spongioplasty, which he has introduced, has definitely made a big difference. So thank you once again to all the experts who have joined us today. So I would request now Dr. Gyanendra Sharma to please come in for his brief comments. We will have their brief comments and then we will invite queries. Yes, Dr. Gyanendra Sharma, please.
Yeah, thank you, sir. Thank you for inviting me to be part of a wonderful session, academic session. I would agree. He missed Dr. Asopa, sir, and Dr. Amilal Bhatt, sir. And it's a request to all presenters, especially the young PGs, that when you are making a presentation, do make a search for the Indian contributions. A lot of Indians have contributed immensely in urology, and it is imperative on our part to include their names in that. Now, sir, few practical tips that I can suggest to the residents is that whenever they start doing hypospadia, then sometimes they find a very good urethral plate. Immediately the incisions are planned and the dissection starts. But the first thing that they should do is put in a urethral stent, be it a infant feeding tube, which I routinely use, or whatever they are comfortable with, because sometimes they would come across a prostatic utricle, and then once the incisions are made, it's very difficult to pass something which is getting stuck in the prostatic utricle. One trick that I learned by experience was, if it is getting stuck in the prostatic utricle, keep the infant feeding tube there and pass another infant feeding tube by the side of the other tube, and it usually goes into the bladder. Use a small sized infant feeding tube. Naveen has covered things excellently, but I think one slide regarding the choice of suture material would have been necessary. And usually I use 6O Vicryl on a 8 mm needle in children. Third is like his statement in one of the slides that as the age increases, the results are poor. Now, somehow this has got ingrained in the Western literature, and this is purely based on one paper by Hensley, which was published in Journal of Urology. A number of people are now doing adult hypospadias. I published it in BJU in 2005. That was probably the first adult hypospadias repair using tip technique. And the results are equally good. The basic thing is, if you are using the native urethral plate, maintaining good vascularity, the results will be good. A lot of people initially, when they have complications, they attribute it to infection. I would say you have good vascularity, infection is never going to be a problem in a structure like penis, which in itself has very good vascularity. Two last points. One is, how do you assess that the urethral plate is good? I think long back there was an article by Holland which says that if the width of the urethral plate is 8 mm and it is supple, it is supposed to be good. Now, I had few personal communications with Dr. Warren Snodgrass, and I have been incorporating the surrounding skin also during the repair. And lately, for the last 3-4 years, I don't even incise the urethral plate. I use the surrounding skin, and I feel that the subsequent risk of new stricture formation in a narrow urethral plate is avoided by this way. But two articles where they have calculated the urethral plate divided by the diameter of the urethral plate once it is incised, that ratio has been utilized. I think it is by Tahir and Pipi Saleh, who said that if you divide the width of the urethral plate by the width of the urethral plate once it is incised, and if it is more than 0.5, you go for a TIP repair. But if it is less than 0.5, then you use what is called as a snot graft repair. And they have further enhanced it by taking certain measurements. And I think these articles, the residents would be better if they go through it. And the last practical tip is, A lot of people, when they want to reconstruct the glans, they are worried about the glans dehiscence. And I think the trick lies in preventing it is to mobilize the glans wings in such a way that they are virtually parallel to the operating table. So you are able to approximate them without any tension. So no tension, good vascularity is the essence of a good hypospadias repair. And I would end my comments with those words of Dr. Amilal Bhatt sir, which are always echo in my mind whenever there is a talk on hypospadias, that the job of a hypospadiologist is to finish what God has left unfinished. Just what is left open, you just close it. I think, Naveen, you did a wonderful presentation of a very complex topic in half an hour. Congratulations for the same. Thank you, sir.
Thank you. Thank you, Dr. Gyanendra. Dr. Gyanendra is a senior consultant urologist from Sholapur. He is also part of the Indian School of Urology and also the part of the editorial committee of our Indian Journal of Urology. Many of his articles have been cited in Campbell's Urology also. And he made very few very important, pertinent points. Yes, we always have to put a feeding tube before we start the surgery on hypospadias. There is always a chance that the urethral tube may not go easily through the passage, mostly because of the prostatic utricle. And about the suturing, the type of suture to be used, Vicryl or PDS, the size 50, 60, or 70, and the needle size. Again, this is very important. And I think the last few, one was his article on adult hypospadias, and the usual thought that the adult hypospadias behave or prognostically are not that good, probably is a myth, as he is saying, because what we feel is that the vascularity and the plate is all much better in adult patients rather than in children. The only drawback probably is that because of the frequent erections, there might be some breakage of the suture line or something, which probably I don't know whether it is true or not. But anyway, very important points made. So thank you, Dr. Gyanendra, once again. And
Thank you, sir.
thank you. And I would invite now Dr. Takwani. Takwani, again, is a very senior consultant urologist from Junagadh, Ahmedabad, is part of the Indian Pediatric Urology Association. So please, Dr. Takwani, you're most welcome. Please go ahead with your comments. Yes.
Thank you, sir, for inviting me, and very good deliberation from Dr. Naveen. Naveen, rather than giving a long list of the comments, I would like to interact with you for a couple of points. Because I think there is some misunderstanding or some sort of short understanding. You said in the last couple of slides that you are clearing the Cody, initial Cody, with the dissection of the skin, dartos, and buccal fascia. Now, can you tell us that when you start dissecting first, what is your plan? Dorsally and ventrally.
First, we start dissection
In
of
degloving, what exactly you do by degloving?
first, we give a circumcision incision.
That is true. What you are doing in degloving? What you are aiming? Degloving, what you are aiming to release?
To release the Cody, sir.
Cody, but where you are dissecting?
First, we dissect the penile skin.
What are the structures that you incise? So
After
what
that-
is actually, meaning is that when you are degloving,
Will it
you
go,
are
see, your degloving dissection will go deep to the buccal fascia, or it will remain superficial to the buccal fascia? Because you said that the degloving will clear my Cody contributed by the skin, dartos, and the buccal fascia.
Sir, skin and dartos fascia, not buccal fascia.
Yeah, not buccal fascia. So the importance of the understanding exact anatomy of the hypospadias penis or penis and hypospadias penis is very important. So give me the see in hypospadias. Hypo means under and spadion means there is a opening or fissure, or you can say, right? Now, what is deficient exactly? So the hypospadias is formed. What is exactly deficient anatomically? So hypospadias is formed.
Sir, in hypospadias, there is a ventral deficient of prepuce skin, ventral deficiency of
Prepusal skin or penile skin also?
yes, sir.
Penile skin also deficient ventrally or only prepusal skin?
Sir, prepusal skin is deficient ventrally and
Okay.
penile skin.
Also, right then.
And sir, deficient dartos facie also.
Okay. Anything else?
Is sponge.
Bucks fascia is also deficient. Third layer is a bucks fascia. That is also deficient. Right? And then under the bucks fascia, what comes?
Sir, corpora albuginea.
Spongiosum. Spongiosum is also lay open. And
Yes, sir.
sometimes it is deficient. And then
Yes, sir.
comes the urethral plate. So what is there? So first is the urethra surrounded by the spongiosum, covered by the bucks fascia, overlying by the dartos, and overlying by the skin. So all these are abortive, small to large level, right? All these things are deficient, except leaving the very distal hypospadias. There maybe it is a problem with the skin and the dartos, or maybe with the spongiosum, right? But
Yes, sir.
for most of the other cases, you have to see layer-wise this problem, that it is skin bugs patient. And last thing is that you told me about the Nesbit, right? And also about the Baskin. Why the Baskin has come when the Nesbit was working very well?
Sir, in this Nesbit technique, we do a elliptical incision on tunica at the greater curvature of the penis.
Fine. Tunica, you put a incision, you took out the wedge, and then you sutured. But
Yes,
what
sir.
was the problem? Which anatomical thing goes against the Nesbit dissection?
Sir,
You didn't mention this. While you talked about the Nesbit, while you talked about the Baskin, you didn't mention any specific thing which anatomically you to keep into the consideration while doing this procedure.
Sir, in Baskin technique, we first remove the dorsal neurovascular bundle. But
In which Baskin?
in Baskin, sir, in Baskin,
In
midline-
Baskin, Baskin, you are taking 12 o'clock.
Yes, sir.
Where is the neurological bundle there at 12 o'clock?
11 and
Baskins, yeah. So what he probably his
No,
slightly
you have a very excellent teacher in the form of sir. But see, the thing is that I really genuinely tell you two things. You did a wonderful job, but thing is that you start with the anatomy, right? Read anatomy of penis, read anatomy of the hypospadias very much. Maybe sometime in exam you stuck with the anatomy related questions, arterial supply of the penis, because it's very important, na? How it goes, how the two layers of the dartos receive the blood supply, so you can preserve the dartos flap, which is most of the time many things are our repair depends upon the dartos second layer, right? So all these things are very important. That what I wanted to convey, that be good in anatomy. And second thing is that what I feel that you have a very big institute and there are good number of hypospadias surgery. So try and take photographs of those. Almost you will get a photograph of almost each and every step. You will get a photograph of Baskin, you will get Nesbit, you will get the photograph of the dartos flap, the Duckett's procedure, or you can say Asopas procedure, or spongioplasty. What I say that future, try to replace those typical photographs which are available almost in every presentations available on the YouTube or on the websites, right? And replace it with your own institute photographs which are there in the institute bank, photograph bank. Thank you once again for incorporating me and allowing me to make comments. Thank you.
Thank you, Dr. Takwani. Very, very important comments made. One about that you should always know the proper anatomy of the penis, the blood supply, everything before you go for the surgery of these patients. And secondly, again, I would be grateful. I'm really grateful to you to reminding us about taking our own photographs in the presentation, because in our institute, we are doing almost every day one hypospadia.
Yes, sir.
Almost every day. So there are thousands of photographs that we can have, and I'm really sorry that we are not incorporating our own photographs. So
We were used to keep, sir, our photograph bank. So any resident, on the permission of the concerned person, they can utilize these photographs, and they have to surrender those photographs again. Is the presentation to again to the institute bank. So that is how the institute was preserving and improving on those things.
Right. Thank you. Thank you. Thank you very much, Dr. Takwani, for those very wise comments. And now I would request our own Dr. Amilal Bhatt, who has really contributed immensely in hypospadias surgery. Dr. Bhatt, you are most welcome for your comments.
Thank you, Dr. Shivam. Naveen has done a good job to summarizing the hypospadias in half an hour, and he has covered almost all points, bearing few. There are simple thing. One thing is that this is message for the residents and beginners. Hypospadias is very simple surgery. Don't go ahead when don't be afraid of doing the hypospadias. You start with and you will get. Second thing is everything is written or everything is lies on the shaft. You just have to read it and analyze and utilize it. Two. Number three, as far as possible, you see the normal thing, because the urethra is not simply a tube. Urethra, there is urethral replacement is urethra only. So try to preserve the spongiosum in all cases and try to create a normal or a near normal urethra, which is using the existing tissue or with the addition of the tissue. These are the few points. Rest, most of the things they have covered. I think I compliment and congratulate your department is already doing very well, and they should go ahead with this one and add one. Another important point that the glass dissection, yes, they are the key points in the raising good glandular wings is medially when you are raising the glandular wing, they should go up to the tip of the corporal body and lately on the lateral border of the shaft. So if you mobilize to that extent, then you will rarely have a glans dissection because you can raise the adequate glandular wings. Many a time, if it is short, the glandular wings are short, then you can, glans is smaller one, then you can use a graft and give a deep incision in the graft, and that graft has to be taken up to the tip of the meatus so that you can have a better glansplasty. These few points, and I think you should go ahead with your rest of the presentation. Things are very good.
Thank you, Dr. Bhatt, for your wise comments. And I will just, I really appreciate your comment that Dr. Gyanendra had reminded us that the job of the hypospadiologist is to finish the unfinished job that God had done. So that was really good, and you have done really well by adding your contribution by spongioplasty, by granuloplasty, and the prepucioplasty, which usually makes hypospadias almost a normal phallus. So thank you once again. Thank you very much. So what I would do now, I will just briefly summarize for the benefit of the residents, and then I will take the MCQs. So hypospadias, we all know, is the commonest congenital anomaly, occurs in 0.3 to 0.7% of live male births. There are various types of classification. One of the recent classification is that hypospadias can be divided into one which is probably unknown and is not usually told, is the form thrust. Form thrust is incomplete or a partial hypospadias. Many times what we would see is a dimple at the glans, or sometimes a small ectopic urethra, or sometimes an asymmetrical foreskin. These are part of the form thrust, and this occurs in 5 to 10% of the cases. Secondly is the standard hypospadias, and they are usually nowadays divided into the two types only. One is the distal and the proximal. Distal is the pericoronal, that is just the proximal glands, or coronal, or just subcoronal. That is the distal hypospadias, and any hypospadias on the penile shaft will be proximal hypospadias. And the third is the severe hypospadias, where it is either penoscrotal or perineal hypospadias, or associated with other abnormalities like undescended testes, or the glans is less than 14 millimeter in size, which makes it a severe kind of a hypospadias. And the fourth variety is the other variants of hypospadias, which look like hypospadias, like congenital chordae without hypospadias, or megameatus with intact prepuce. So these are the four types of how the hypospadias can be classified. And secondly, hypospadias can have various syndromic manifestations also, like a Dennis-Drash syndrome, the Wager syndrome, the Oppit syndrome, the Fraser syndrome. So you have to be very careful when a patient presents with hypospadias and you find some other abnormalities in the body. You need to be aware of these syndromes also. When the hypospadias presents with either unilateral or bilateral cryptorchidism, or if it is a severe variety like penoscrotal or perineal hypospadias, you must always evaluate for DSD. That is the intersex which was known earlier. So these are very important things, and we all know hypospadias, the pathogenesis is due to either genetic or environmental factors, which results in disruption of the androgenic stimulation for the formation of the urethral tube and the phallus, which results in hypospadias. There are various risk factors which he has already elaborated. Then there are various genetic reasons also. Studying the genome of hypospadias patients, it has been seen that there are various SNPs, single nucleotide polymorphisms, which have been evolved, which are there present in many of these patients of hypospadias. It could be familial also. So while evaluating a case of hypospadias, the differential diagnosis is usually with injuries during circumcision, can be sometimes have a differential diagnosis with hypospadias, or sometimes a duplication of urethra. So can mimic a case of hypospadias. When we do the evaluation of these patients, we need to be careful about the penile stretched length, the glandular size, the foreskin, the penile chordae, the severity of the chordae, and then the presence of undescended testes present or not, and the scrotum development also. Well, there could be sometimes a penoscrotal transposition also, which we have to take care of in these patients. When we talk about the various surgical management, basically they could be of three types. One is the tubularization, where we do simply tubularize the urethral plate if it is wide enough, and we can incise the plate to make it a tip procedure or a Snodgrass procedure. And sometimes we could put a graft in the incised urethral plate, which makes it a Snodgraft or the Hypospadias procedure. And another is the island onlay flap, which could be ducats, Hypospadias, and other procedures. And the third is the two-stage procedures, which he has described. And the tube procedure, the tube urethroplasty is almost obsolete nowadays. If we have to make a tube, it is better to do a two-stage procedure rather than a single-stage procedure. Follow-up, again, is very important in these patients. Never stop following up these patients even till the adulthood. So it has been seen that many of these patients may have problems when the puberty starts. So they have to be followed up in the puberty, and sometimes even till the 18 years of age, when the adulthood starts, you have to see the result, because many of the patients may develop some kind of chordae, stricture, or cosmetically not good penis, which may require surgery. So this was all about hypospadias in brief. So I would now start with the MCQs, please. The first question, the level of hypospadias is typically defined by what parameter? At the initial office visit, by identifying the location of urethral meatus, by calculating the level of penile curvature based on the location of the meatus when inserting a feeding tube in the operating room, after penile degloving, taking into account both location of the urethral meatus and the degree of penile curvature. D. Yes, I think this is important because after degloving, the location may shift, and when you have the penile curvature, when you do the correction of the curve body, the meatus may recede. So that is important, I think. So the answer should be D. Yes. The traditional method of diagnosis and risk stratification was based on the location of the urethral meatus at the time of diagnosis. Based on a number of different variants, the most accurate assessment of the degree of hypospadias is based on the location of urethral meatus after penile degloving, combined with an assessment of the degree of penile curvature. Take note of the glans separation, although parts of assessment is present in the majority of boys with hypospadias. The second question. A 10-year-old boy presents with mid-shaft hypospadias after 7 prior operations on his penis. He appears to have ventral curvature greater than 30 degrees and has been circumcised. There is visible scarring between the meatus and the glans, and there appears to be a significant penoscrotal webbing also. The best surgical approach for him is a redo tubularized incised plate operation, a flip-flap preoperative urethroplasty, island onlay flip preoperative urethroplasty, inlay buccal graft urethroplasty, and 2-stage buccal graft urethroplasty. Our residents are saying 2-stage buccal graft urethroplasty. What do you say? Any of the experts?
Yes, sir. Correct. It would be 2-stage buccal graft urethroplasty.
Right. So you don't think inlay buccal graft urethroplasty in 1 stage is as good as 2-stage?
Sir, not with such a severe ventral penile curvature and scarring.
Right, exactly.
Most of the skin is probably not available.
Right.
So even if you get something to make a tube, further covering the tube with the healthy skin won't be probably easy here.
Yes.
So you have to bring some first something, and then.
Right. So the answer is 2-stage buccal graft urethroplasty. Visible scarring is a relative contraindication to tip or flip-flap operation. The penoscrotal webbing and curvature suggest that there is a lack of shaft skin, as our expert said, particularly on the ventral portion of the penis, which will limit the ability to perform an onlay procedure. The best plan is to excise the scar tissue and perform a staged buccal graft urethroplasty. Next question, a 6-month-old male is referred for hypospadias. On examination, is found to have a dorsally hooded prepuce, ventral penile curvature, a glandular meatus, and a normal scrotum. The parents should be informed that straightening the penile curvature most likely will require a skin degloving and ventral dartus dissection, multiple dorsal midline plication, ventral corporal grafting, transection of the urethra, single dorsal plication, and ventral corporal graft. Yes? A, skin degloving and ventral dartus dissection only. So you do not know exactly what is the, because in the glandular hypospadias, usually you have a mild kind of a chordy or a glandular tilt that you call. In those cases, probably they may require just a ventral dartus dissection. But still you do not know. What do our experts say?
Sir, I would agree with what you are saying. A would be what would serve the purpose most of the times. But then hypospadias does bring up surprises at times.
Yeah, exactly. So the counseling should be done in that way. You never guarantee that this you will be done with only degloving and ventral dartus dissection. So, but in majority cases, yes.
One more point to be taken
Yes.
into consideration.
Yes.
The glandular or coronal hypospadias, you have to see the length of the hypoplastic urethra. Many a time you will find the opening is at the glans or even at a coronal level, and length of the hypoplastic urethra is 2 centimeter or going up to mid penile shaft or even up to the penoscrotal junction. So those have to be treated accordingly. Second one is alongly, maybe that most of the cases there is a mild curvature, but in many cases these may fall into in between the chordae without hypospadias. So seeing the curvature, many a time if it's a severe curvature, then it has to be go accordingly.
Right. Very, very important comment made that many times you have a hypoplastic urethra, though the meatus may be at the corona, but rest of the urethra is hypoplastic, then the actual meatus may recede back into the penile shaft. So we have to be very careful about that. The fourth question, a patient with penoscrotal hypospadias has 90-degree of ventral curvature prior to making the initial incision. After the penis is fully degloved, artificial erection reveals residual curvature of 15 degrees. The best next step in correcting the curvature is transection of urethral plate, perform double grafting of corpora cavernosa, proceed with urethroplasty, perform a midline dorsal plication, perform midline dorsal plication and ventral tunica vaginalis graft corporoplasty, then complete a single stage urethroplasty repair. Yes, residents? Pardon? E. Some residents are saying E, and some are saying C also? C also. So because the curvature is only 15 degrees, usually when we classify curvature, straight penis and less than 15 degrees is classified as a normal. They usually need not be kind of repaired for curvature. So if it is 15 degrees or less, probably they may not require any kind of surgery. But yes, if it is 15 degrees or more, then they may require a midline dorsal plication. Any comment from our experts?
Yes, sir, would agree with it theoretically, but I would tell you a very interesting conversation which I had with a Canadian urologist.
Yeah.
He said that all those patients who underwent sort of chordae correction and hypospadias repair with say less than 15 degrees, by the time they reached puberty, the chordae was much more significant. And in fact, he is trying to come up with the data saying that should we postpone hypospadia surgery till they attain adolescence? So I think if there is some curvature which is visible on table, it's better to correct as much as possible, because you never know how much amount of fibrosis and subsequent things would again accentuate the curvature.
Very important comment. Dr. Bhatt and Dr. Takwani, any comments?
Yeah, I would like to make a few comments.
Yeah.
There are two things. One thing is, I think I will make this statement. We should stop using the fibrosis. There is no fibrosis for the chordae except in these redo cases.
Yes.
Whatever chordae is because of hypoplastic spongiosum. So one is. Second one is that you see when we had the causes of the curvature, so we have to correct the all causes. If it is because of only the skin and dartos fascia, then penile degloving, even the less than 15 degree is going to cover up. But if we leave that one, there is some point of the buccal fascia or the spongiosum segment, which is causing even a 15 degree is going to increase later on. So if need be, mobilize the urethral plate and spongiosum, so that will cover the causes of buccal fascia and spongiosum, and the recurrence of the curvature is least likely at the adulthood.
Right. So very important point. You have to
Agree with Shivam with the Dr. Amilal Bhatt. This is what the juniors as well as the residents should understand: the anatomical and embryological reason, and then anatomy. See, anatomy that correct first the skin and dartos, then correct the spongy bucks and spongy tissue, and then correct the urethral plate lengthening. And if not possible, then work on that. If you have a choice to not to go for a dorsal plication, otherwise try little bit of dorsal plication, and still not possible, then something related to the plate sacrifice the plate in you to do. But we have to make sure on table that we are correcting the CODI because this 15, 25, 30 is very difficult to standardize.
Right, right. Yes, a very important comment made by both the experts that you have to take all the measures and the steps of CODI correction before you label it as a residual CODI. So once you taken all the surgical steps, then only you have to take other steps, whether you want to correct the residual CODI. I think we have exceeded our time limit. So I would stop here and I would thank all our experts for attending our session and joining our session. Thank you very much.
Shivam, I would like to make one comment.
Yes, please go ahead.
I disagree with you on this point that flaps are obsolete now. Now, so you see, basically we have to understand the anatomy, physiology, and surgical principles. Flaps have better blood supply than the grafts. What
Did
we
I
were
say flaps
using
are
and what we
obsolete? I didn't say flaps are obsolete. I said the tube flap. Tube flap is almost not.
yeah, that's
Yes.
tube flap also I am telling.
Yeah,
Tube
tube.
flap also I am telling. So
Yes.
there you see, go and see my modification. You see, application of the flap was improper. Whatever the thing which we review and see was that improper application of the flap rather than the flap itself. So flap has a better blood supply, then why the result should be poor? So for seeing these, I have made 8 modifications in flap tube repair. Those modification will clear all those, reduce these complications, and complications are similar one. And I reviewed this one, single stage and 2-stage repair, and single stage and 2-stage repairs are almost equal in recent. Go through my chapter, that one, then the people will understand about this. Thank you very much. Sorry for this intervening.
Thank you, Dr. But we will definitely go through. And Hypospadias is such a interesting and a very vast chapter that we need to devote more classes on that. Thank you very much.
Yeah.
I think Dr. Gyanendra, would you like to make a last comment?
Yes, sir.
Yes.
Sir, the only advice to the residents and juniors who want to venture into this field is there are more than 200 types of hypospadias repair which are described. 5 to 10 are which are commonly being done. As you keep doing it, you will realize what works best in your hand. Stick to it.
Yeah.
Yeah, I always say how to play a cover drive. Virendra Sehwag, Sachin, Virat Kohli, and Dhoni all will play a cover drive in a different way. What suits you, you stick to that.
Right. No, very, very nice comment made. And thank you once again, Dr. Gyanen, Dr. Bhatt, Dr. Takwani, for
Thank you,
joining
sir.
us today. And all our residents and faculty who might have joined us today on Zoom and YouTube. Thank you very much and have a good day. Thank you.
Thank you, sir.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.